Our next speaker for this morning's session, Dr. Leanne Norris, completed her PharmD degree at the University of South Carolina College of Pharmacy in Columbia in 2004. She then completed a PGY1 residency at the Moses Cone Health System in North Carolina, and then a PGY2 residency within Moses Cone, also in Greensboro, a couple of years later. She's now assistant professor at the South Carolina College of Pharmacy, and her practice site is located at the William Jennings Bryan Dorn VA Hospital, where she is clinical pharmacy specialist in medical oncology and hospice and palliative care. She was the 2010 recipient of the Hematology Oncology Pharmacy Association New Practitioner of the Year Award, and her research interests include supportive care, hospice, palliative care issues, and medication safety. Please join me in welcoming Dr. Norris.
All right, good morning. How is everyone? Yeah? All right, so quick show of hands. Anyone in here work in oncology? Okay, so quite a bit. That's awesome. So you guys can just tune out, right, for the next hour and a half. Thank you to ACCP for having me back. I think this is like my 6th or 7th year. I will have to say, it never gets any easier doing this. The room always seems either longer or wider. So it's still kind of that gut check when you walk in the door. But thank you for being here on a Saturday morning. I'm always very excited to talk about oncology, and especially in the area of supportive care. Okay, so let's start out with our learning objectives. We're going to identify, assess, and recommend appropriate pharmacotherapy for managing common complications of cancer chemotherapy. We'll spend a lot of time talking about nausea and vomiting, myelosuppression and the appropriate use of growth factors, infection, anemia and fatigue, cardiotoxicity, and extravasation injury. And you'll notice that there are a lot more topics that are covered in your oncology chapter. I've kind of pulled what I think are the most important topics, and probably topics that would be areas for potential questions on the exam. So we'll kind of get into that. Number 2, we're going to assess and recommend appropriate pharmacotherapy for managing cancer-related pain. Assess and recommend appropriate pharmacotherapy for oncologic emergencies, and really we'll kind of go over these kind of quickly at the end, including hypercalcemia, hyperuricemia, and spinal cord compression. Okay, so let's go ahead and get into the first case. A 60-year-old woman was recently given a diagnosis of advanced non-small cell lung cancer. She will begin treatment with cisplatin 100 milligrams per meter squared plus vinorelbine 30 milligrams per meter squared, which is the most appropriate antiemetic regimen for preventing acute emesis. So if everyone will kind of get their cards out, is it A, aprepitant plus palinositron plus dexamethasone, B, aprepitant plus prochlorperazine plus dexamethasone, C, aprepitant plus granisetron plus ondansetron, or D, lorazepam plus ondansetron plus metoclopramide? All right, so a show of hands. Okay, good. So I'm seeing a lot of blue, which is excellent. Okay, so quickly we're just going to discuss the common definitions of nausea and vomiting. I'm sure most of you are familiar with these, but just as a reminder, nausea is the most common complication that our cancer patients unfortunately suffer from after the initiation of chemotherapy. You know, nausea is that inclination to vomit, whereas vomiting is actually the expulsion of gastric contents. And then there's the retching. The retching is the labored movement, which can often be associated with, periods of pain after retching, or periods of retching if they have had those types of issues for a longer period of time. We find that most of our cancer patients do suffer more from nausea than from vomiting. Not every patient, but we know that every patient is affected by chemotherapy very differently, and so sometimes it is hard to assess or determine how severe those patients are going to experience these symptoms. Other kind of key definitions to remember are the differences between the varying types of nausea and vomiting. So we have acute, which is considered the first 18 to 24 hours after chemotherapy. Delayed, which is 18 to 24 hours after chemotherapy, and this is the one that sometimes we not necessarily that we forget about, we hopefully as practitioners we're counseling our patients about, but this is really the type of nausea and vomiting that often our patients forget about. So they get chemotherapy on day 1, they wake up on day 2, they feel great, maybe on day 3 they feel fine, day 4 they are extremely nauseated, perhaps making a couple of trips back and forth to the bathroom. And so delayed nausea and vomiting, is really considered any time later than 18 to 24 hours after chemotherapy. So it's really important in regimens or in patients that we know that are at high risk that we do a good job of kind of prophylacting and giving them the appropriate medications for delayed nausea and vomiting. Anticipatory is exactly what it sounds. It's triggered by sight, smell, or sounds due to inadequate control of nausea and vomiting in the past. It's found that if they have a good first cycle of chemotherapy, it's not a guarantee that their subsequent cycles are going to go well, but usually it's a bad sign if they have a really poor first cycle in terms of nausea and vomiting, side effects, etc. So certainly it is an experienced type of nausea and vomiting in terms of, they can walk through the building, smell the same smells, kind of walk into the chemo clinic infusion area, and all of those things kind of bring back past memories of those episodes of nausea and vomiting. And we'll kind of get into that more in the next couple of slides. Then we have breakthrough. This is emesis that occurs the day of chemotherapy despite appropriate prophylaxis. And so that's why it's always good to make sure that you send your patients home with some sort of prophylactic regimen. So we'll get into that more as well. And then finally, refractory. And refractory is where there is a lot of ongoing research and where we do have some kind of not newer drugs, but newer recommended regimens for refractory nausea and vomiting. This is when it occurs during treatment cycles when antiemetic prophylaxis and or rescue therapy have failed in previous cycles. Okay, so just as a reminder of kind of where the vomiting center is, the chemoreceptor trigger zone certainly is where we see most of our effects of our medications that we have now for the use of chemotherapy-induced nausea and vomiting. It is important to remember, however, with anticipatory, this is more associated with that higher cortical center. This is associated with that memory, the fear, the anticipation of getting sick. And so this is why benzodiazepines are typically the drug of choice for this, and we'll kind of talk more about this. Other things, it's always important to kind of rule out other issues. So certainly if a patient is experiencing nausea and vomiting, but perhaps they've recently undergone surgery, perhaps a bowel obstruction or something like that is suspected, then we would perhaps think to use different types of nausea and vomiting medications for those types of symptoms. So I think this pathway is really good just to help you kind of remember and think about where the various types of nausea and vomiting may be initiated from, and then also where the various agents kind of have their action and their effects. Okay, so in addition to, and we kind of assess whether or not someone is going to get nausea and vomiting after chemotherapy in kind of 2 to 3 different steps. One of the first steps that we always want to do is a patient assessment. So we want to look at the individual patient and kind of do a risk factor assessment to determine whether or not we feel these patients are going to be at high risk. And certainly this is a great opportunity for pharmacists to become involved in this patient's care through counseling, et cetera. So what I like to do is I like to go to our patient and kind of have a pretty lengthy conversation about past history of nausea and vomiting. And some of these are very easy. You actually don't have to talk to them to get this information, but some of it you do have to dig a little. So you can see here younger patients or those less than 50 years of age are at higher risk for nausea and vomiting. Certainly females are at higher risk, and if you kind of scroll down a couple of bullet points, you'll see that one of the reasons for that is if they have previously had children and had a history of nausea and vomiting during that pregnancy, then certainly that would be an additional risk factor for being female in gender. Also, history of motion sickness. So this is usually something you're going to have to ask the patient about. History of car sickness, motion sickness on, roller coaster rides, etc. All of this would be included. Poor control of nausea and vomiting in previous chemotherapy cycles. So if they're a patient that perhaps was diagnosed with cancer a couple of years ago, they underwent treatment, they've been in remission, and now their cancer has come back and they're going through chemotherapy again, knowing kind of how they did in terms of nausea and vomiting with that first diagnosis of cancer is very important going forward in terms of making sure that we give appropriate prophylaxis for these patients. Certainly, history of chronic alcoholism. This actually decreases the incidence of emesis. I've always been amazed in the VA patient population of how well our patients do considering some of the highly emetogenic regimens that we give them. And so it's always interesting to me to ask if they drink alcohol, how long have they drank alcohol, how much do they drink. And so it has been found that these patients that have a history of chronic alcoholism will actually do better. So they will have less nausea and vomiting. And then the emetogenicity of the chemotherapy regimen itself is very important. Okay, so if you look through your chapter that I provided for you, I kind of give a very lengthy history of kind of where we are, where we've been, kind of where we're going in terms of the emetogenicity of the chemotherapy regimen. There are several schemes that have been proposed. There was an original regimen, you can see here, that was broken down to none, mild, moderate, severe. Then we kind of moved into the Hesketh model in terms of ranking the percentage of emesis that would occur. And then now we're into our current model, which is divided into 4 levels for our IV chemotherapy, 2 for our oral. And you can see here the 4 levels really are divided: minimal, low, moderate, and high emetogenic risk. And this is based off of the percentage of patients that would actually get nausea and vomiting if they were not given any type of prophylactic medication. Okay, so certainly our highly emetogenic risk patients are our patients that we're really concerned about. And to be honest with you, I don't write any of the questions for BCPS, but I would think that this would be an area that they would likely target for questions, just because a lot of our newer agents are utilized for prophylaxis in the highly to moderate kind of emetogenicity range. Then there's the levels for oral chemotherapy, as I stated a few minutes ago. These are broken down into 2 separate categories: either prophylaxis recommended and PRN recommended. And you'll see that I have those outlined in your chapter. Should you memorize all of those medications? No, you should not. Kind of one big key, or maybe 2 kind of pearls in terms of studying. I would suggest that you keep in mind that the majority of the oral chemotherapy agents are in the second category, where it's, as needed. And so you'll find that most physicians are going to write them a prescription, or at least the physicians that I've worked with are going to write them a prescription for some sort of prophylactic antiemetic once the oral chemotherapy is initiated. In terms of kind of how do you digest the levels or the categories for where the chemotherapy agents kind of fall into place, I would suggest kind of memorizing or learning a couple from the highly emetogenic category, learning what's kind of in the minimal category, and recognizing that kind of everything else is in between. I think that's the best way to kind of study for this exam in terms of where I think you'll get targeted for questions. So for the highly emetogenic category, certainly cisplatin, so that's a hint from this case, that cisplatin is considered highly emetogenic. It used to be only high doses of cisplatin. Now it's in the guidelines, the National Comprehensive Cancer Network guidelines. They're recommending that every patient who gets cisplatin, regardless of what dose, this regimen would be considered a highly emetogenic regimen. So anytime you see cisplatin, certainly that should be a red flag. This could be considered a highly emetogenic regimen. Then also the other kind of regimen that's highlighted is AC. AC stands for adriamycin or doxorubicin and cyclophosphamide. Certainly they feel that this regimen, because the majority of this time when this regimen is utilized, it's utilized for the treatment of breast cancer in female patients, and because we know female patients are at a higher risk, that's another reason why this category is kind of grouped into the highly emetogenic category. And if you follow the old Hesketh model for how you kind of categorize multiple drugs in one regimen, this would kind of place you up into the higher regimen if you individually look at each agent and then make an assumption based off of the two of them combined. So AC and cisplatin certainly considered highly emetogenic. Other things, very high doses of cyclophosphamide, which you would likely only see in bone marrow transplant cases. Those are kind of the major three, I would say, that kind of stand out in my mind. Then you have your minimal, and this used to be low, so I still have to stop and think about the minimal category and what's in this category. You'll see that if you look in your chart, a lot of the agents in this category are monoclonal antibodies. So we know that monoclonal antibodies don't really contribute to emetogenicity, although I have seen like 1 or 2 patients that have gotten sick off a monoclonal antibody. I think it was something else totally unrelated. But anytime you see a monoclonal antibody either used by itself or added to a regimen, it's important to recognize that adding that to a regimen or when it's used in as a single agent does not contribute to nausea and vomiting. Okay, so there's a couple of those in there: cetuximab, bevacizumab, et cetera, rituximab. All of those would be considered minimal risk. Then you have your Vs. So vinblastine, vincristine, vinorelbine, all of those agents are considered minimal. Okay, and so then you have your other agents that would kind of be in the middle, your taxanes, oxaliplatin, carboplatin. Those are kind of considered in the moderate. And so that's kind of how I would recommend that you go about looking at these agents and kind of where they fall. Again, I don't think if they're going to ask you a question about nausea and vomiting, I don't think they're going to be very tricky. They're going to ask you a question that's kind of clearly defined in the guidelines, so either highly or moderate emetogenicity or very low. And that, again, that's just my personal opinion. Okay, so kind of thinking back to this case, certainly we're going to go through the patient factors. So remember, this was a patient with non-small cell lung cancer. Cisplatin and vinorelbine were the agents that were utilized for the treatment of this cancer. You can see that this patient was female, so I gave you that information in the case. We talked about how cisplatin is in the highly emetogenic category. So again, that should be a red flag right away that we need to use a regimen that is effective against perhaps both acute and delayed nausea and vomiting. So some of your other options, prochlorperazine is generally not utilized for highly emetogenic chemotherapy. It is a great agent to use as prophylaxis for, say, breakthrough, perhaps even an agent that if you haven't utilized it already for refractory nausea and vomiting, but it's typically not utilized in our highly emetogenic regimens for prophylactic use up front. Then you have lorazepam. That was another option in the options that were given for the case. It's useful for minimizing anticipatory symptoms. We'll get more into that, but it certainly should not be utilized by itself in terms of prophylaxis. And then we have aprepitant for the highly emetogenic chemotherapy and regimens causing delayed symptoms. You'll see that dexamethasone is used in combination with a lot of these products because it has been shown to improve antiemetic activity by 10 to 20%. And that's one of the reasons why if you were to ever go and pull any of the antiemetic trials, you'll always see dexamethasone kind of utilized in combination with these regimens. And you'll also see that our 5-HT3s are utilized in combination with some of these newer NK1 agents as well, because it would really be unethical at this point, knowing what we know about 5-HT3s, to study a newer agent with a newer improved mechanism of action without giving patients at least something for nausea and vomiting. So that's why these kind of therapeutic agents are used in combination and are thought to be efficacious or more efficacious that way. Low-dose metoclopramide has activity similar to phenothiazines. We know that higher doses block serotonin receptors, and years ago, before we had 5-HT3 antagonists, these kind of were the workhorse agents for treatment or prevention of chemotherapy-induced nausea and vomiting. The disadvantage is that we know that we did have to use it at very high doses in order to hit those receptors, and so unfortunately it caused a lot of Parkinson's-like syndrome type side effects when they are used at these doses. So that's why we really no longer use this therapy primarily for highly emetogenic regimens. But it can be utilized for preventing and treatment of delayed therapies, and it was often a great agent for delayed nausea and vomiting. And so, again, you can't kind of really rule it out as an option, but it's not generally the first thing that we're going to think about in terms of treatment for delayed nausea and vomiting. Okay, so the answer is A, aprepitant plus palonosetron plus dexamethasone. I'm not sure how specific they'll get on the exam in terms of what you need to know as far as dosing. I would kind of refer you back to the chapter. There are a couple of different dosing schemes that I've provided for the use of aprepitant. It did initially come in an oral preparation. It's still available that way, but that was the way we mostly utilized it, 125 milligrams by mouth on day 1 and then 80 on day 2 and day 3. Since then, we have the prodrug agent fosaprepitant that I would say probably 90% of the infusion centers are using at this point because it is IV. It can be given one time and you don't have to repeat any subsequent doses. Okay, so I do think that's important. You may want to put a star beside that. We do have 2 newer agents that I included in the chapter this year. I'll be completely honest with you, I have no experience using these agents. Our facility mostly uses fosaprepitant. I've kind of asked around. I don't really know of anyone that's really using relepitant yet. I have discussed with a few colleagues, I guess, that are using the neutropenia combination and the palonosetron combination. So I don't expect, honestly, a lot of questions about that on the exam. But, I do think it's important to recognize now that there are kind of 2 other NK1 agents that might be utilized and have been approved for the use for prophylaxis for highly emetogenic regimens. It appears to be a class effect in terms of side effects. One of the things I always like to kind of make sure I tell patients about is hiccups. So in NK1 antagonists, patients will often experience hiccups. I think clinically it's more common than it's actually noted in the package insert. I would say that more than 75% of the patients that we treat with aprepitant get hiccups. So it is something important for them to know. It can affect quality of life, obviously, and so kind of making sure that you counsel them about the potential of this occurring and recognizing that they may need some additional medications, unfortunately, to assist with those hiccups is always an important education moment. And then the only other thing I wanted to make sure I commented on in terms of this case was just recognizing that palonosetron was used here in this case as kind of like the preferred 5-HT3 antagonist. I would have to say that I think that would vary if you depending on what institution you work at in terms of what 5-HT3 is used. Palonosetron is a little different than the other 5-HT3s in that it has acute and delayed effects. So it has been shown to combat nausea and vomiting, within the first 24 hours and then post 24 hours as well. It is it is a lot more expensive than your traditional 5-HT3, especially in the world of generic Zofran. And so if your facility is not using this, cost is probably one of the major reasons why. Okay, so if you look in the chart in terms of what the guidelines say for recommendations for nausea and vomiting, absolutely you want to use an NK1, a 5-HT3, and a steroid for highly emetogenic regimens. Okay, and we talked about kind of the key things, risk factors, drugs that are utilized. The option can be for moderate emetogenic regimens. It's kind of left up to the physician's discretion in terms of whether or not you want to use an NK1 regimen. Okay, so it's not mandatory must do, but it is an option certainly. And so those are kind of where you'll see these NK1 regimens utilized, either highly or moderate anti-emetogenic regimens. Okay, so moving on to patient case number 2, which is the most appropriate regimen for anticipatory nausea and vomiting, and certainly this is kind of building off the first case. So if we know that we're putting them on an aprepitant plus a 5-HT3 steroid kind of base regimen, then what would we add on to assist with anticipatory? So is it A, aprepitant plus dexamethasone, B, aprepitant plus metoclopramide, C, ondansetron plus dexamethasone, and D, aprepitant plus ondansetron plus dexamethasone plus orazepam? And I think I've kind of given you this answer multiple times. Yes, I think I need to make this question a little harder next year. Okay, so one of the interesting things I think about the treatment of chemotherapy-induced nausea and vomiting certainly is anticipatory nausea and vomiting. As we talked about, it can be triggered by sight, smells, sounds, and really just a previous history of inadequately controlled nausea and vomiting. And I tell this story every year, but I think this story is so great in terms of how to think about what happens in a patient. So I worked with one of my pharmacy colleagues that I worked with at a hospital about, 8 years ago. Her husband was diagnosed with Hodgkin's lymphoma. And I get a call in the clinic one day, and she said, "Leanne, I don't know what to do. He continues to have nausea and vomiting. I think he was on his 3rd cycle at this point." She said, "He is on everything that he can be on. I just don't understand what the problem is." And I said, "Well, kind of tell me about his day. Kind of tell me what happens. Tell me what he has to say about his treatment, etc." She said, "Well, he does the same thing. He has the same routine every time he goes to get chemotherapy." So I'm like, "Okay, what is that?" "Well, his mom picks him up. She takes him to IHOP. They have breakfast. Then they go to Barnes & Noble. He buys a book. Then they head over to the treatment center. And then that's where they sit, for several hours while he gets his chemotherapy." I said, "Well, I think maybe what you're describing to me is he's getting anticipatory nausea and vomiting because he's going through the same exact process and routine every time he goes to get treatment. And so he associates that same exact process with nausea and vomiting." And she's like, "Wow, I never thought of that." So I said, really just tried to think about changing up his routine. Now, is that going to work every single time? Absolutely not, because most of the time it's just walking through the facility that can cause anxiety and get patients to start feeling nauseated. But I do think it's important to, as part of the patient education as a pharmacist, to recognize when patients are kind of having these similar symptoms and kind of what you can do to assist in treating this. You'll see that if you look back in the chart in your chapter, every recommendation, regardless of whether it's highly emetogenic, moderate, low, or minimal, will always say plus or minus lorazepam for anticipatory nausea and vomiting. And that's because we are supposed to, as healthcare professionals, do an assessment, especially after the first cycle, to ensure that they are not kind of having these types of symptoms. Okay, so serotonin receptor antagonists are generally not thought to be effective for anticipatory symptoms. So again, one of the options that I gave you was ondansetron plus dexamethasone is really just not a great option by itself. Our kind of highest effective regimen in terms of our regimen that's utilized for acute and delayed nausea and vomiting is typically a great option for delayed, again, but not for these anticipatory symptoms. And remember that a lot of this is because of the effects on the higher cortical center, the memory, the fear, the anxiety, etc. And so then again, aprepitant plus metoclopramide, not a great option. So benzodiazepines, especially lorazepam, or I think in most facilities, lorazepam is perhaps the easiest agent to use because it is available in a couple of different dosage forms. We know that it does have minimal antiemetic activity as a single agent, but it can be useful in combination or as an adjunct for anticipatory. Part of this is that it does kind of cause that amnesia effect. And that's what is thought to help prevent those anticipatory nausea and vomiting symptoms. It also calms patients down. It gives them the relief of their anxiety. Perhaps it makes them a little drowsy. And so that's really what we want, so that they can come in, kind of get treatment, and effectively be treated. And this goes, if you're an inpatient pharmacist that's treating a patient as well, and they get admitted for, an overnight infusion type regimen, this would be the same as well. You want patients to come in to be comfortable, to be relieved of anxiety, and hopefully that will relieve some of those anticipatory subsequent side effects. And then you'll see here it can be utilized for the management of akathisias caused by some of these other medications. So it really does kind of have a couple of different mechanisms. We do know that it has adverse events, obviously. Amnesia is the one that we actually want. So this is, again, what we think is kind of the mechanism of action of why it's effective for anticipatory nausea and vomiting. Certainly sedation, hypotension, any type of perceptual disturbances. But again, some of these side effects are somewhat desirable in this setting. Okay, so getting back to our case, if we had a patient that had anticipatory nausea and vomiting, certainly adding lorazepam to their baseline therapy would be appropriate and would be the best answer. And the only other thing I would say kind of before we move off of nausea and vomiting, don't forget that also in the guidelines, and this is outlined in your chart as well, that 2 other agents are kind of listed at the bottom in terms of plus or minus in addition to your main chemotherapy regimen. So that would either be like a PPI or an H2 antagonist. So as you know, or at least in my experience, majority of patients are already on one of those, it seems, for one reason or another. But if they're not and they're having dyspepsia, things of that nature, certainly adding on one of those agents to assist with those types of symptoms, which we know can exacerbate and lead to nausea and vomiting, would certainly be appropriate. So that's something else to kind of think about going forward. Okay, so patient case number 3. We have a 75-year-old man who has metastatic prostate cancer. The main sites of metastatic disease are regional lymph nodes and bone. And specifically, he has several hip lesions. He has aching pain with occasional shooting pains. The latter are thought to be the result of nerve compression by enlarged lymph nodes. He's been taking oxycodone, acetaminophen combination, 2 tablets every 4 hours, and ibuprofen 400 milligrams every 8 hours. His current pain rating is an 8 out of 10, and he states that his pain cannot be controlled. Which of the following choices is best to manage his pain at this time? A, increase the oxycodone acetaminophen combination to 7.5 milligrams, 2 tablets every 4 hours. B, increase it to 10 milligrams, 2 tablets every 4 hours. C, discontinue the oxycodone combination and ibuprofen and add a long-acting morphine every 12 hours. D, discontinue the oxycodone acetaminophen combination and add morphine every 12 hours. Okay, so a show of hands. Okay, good. So there's actually a little bit of a mixed response, which I usually expect. Okay, so just looking back at the patient case specifics that I've given you, certainly severity of pain is what we're looking at here in terms of selecting the most appropriate agent. We have been told that this patient has a pain of 8 on a scale of 0 to 10, and so we would consider that more severe. We certainly want to make sure that we're selecting a drug and a dose to match the severity of the pain. So if this patient has a less severe pain, then perhaps we would have a different plan for this patient. The other big thing that we always like to think about, specifically in treatment of pain in cancer patients, is the combination products. We know that according to the World Health Organization, it is part of the step process in terms of going from mild to moderate pain management. However, at times when you have patients who have advanced disease, metastatic disease, multiple metastatic areas, that combination products may not be the most appropriate regimen because you are limited in your ability to titrate the medication based off of that acetaminophen product. So I think it's always important to kind of remember that even though, acetaminophen and the opioid combination we know are more efficacious used together, we are often limited by being able to titrate with those products. So I find myself, if they go from kind of moderate pain to more severe pain, I personally find myself wanting to move away from those combination products to prevent any additional toxicity from acetaminophen. Because even though we're counseling patients about not taking any additional acetaminophen over the counter, or if it's an NSAID product, NSAIDs over the counter, we can't kind of ensure that that's not going to happen. Okay, so for persistent severe pain, agents with a long duration of action are more convenient, and certainly there is evidence that shows that NSAIDs may be useful for bone pain. So specifically in this case, patient with metastatic prostate cancer, we know that the primary site of metastases is bone, and often these patients have a lot of bone pain. And so NSAIDs are thought to be a great agent to utilize, as you all know, for bone pain. And so that's one of the reasons why, if you opted to keep this on in this patient to assist with the treatment of his pain, that would likely be a good option. So you can see here the answer is D, discontinue the oxycodone-APAP combination and add a morphine therapy sustained release product every 12 hours. Now, the big thing, and this hasn't changed regardless of if you're treating cancer pain patients or a non-cancer pain patient, but just knowing that if you put someone on a long-acting medication, then you're likely going to have to supplement with some sort of breakthrough agent as well. So making sure that you kind of remember that. And then also, in addition, anytime you put a patient on an opioid therapy, you're going to want to make sure that they have some sort of prophylactic GI regimen in terms of preventing constipation, because we know that that is the major side effect, that patients who are on opioid therapy, they never develop tolerance to constipation. Okay, so now talking about going back to this case. If you remember, we talked about how he has aching pain with occasional shooting pains, and that this is thought to be the result of nerve compression by enlarged lymph nodes. So kind of knowing that, for patient case number 4, which is the most appropriate adjunctive medication for this patient's pain? A, naproxen, B, single agent acetaminophen, C, gabapentin, or D, baclofen. Okay, I think my questions are way too easy. Or you guys are just super smart. Okay, so certainly there are a couple of considerations for pain management. I think recognizing when patients are describing a different type of pain versus your more nociceptive pain, your dull, achy kind of pain, when we start moving into more of a burning, tingling, maybe even a sharp kind of pain, we start to think that perhaps it is a different type of pain and we're going to need to utilize a different agent to treat it appropriately. Adjuvant analgesics are added to opioid regimens for a variety of pain syndromes. Certainly there are newer agents, Cymbalta, et cetera, that can be utilized as well. I think gabapentin is probably the oldest regimen, so if you work in a cost containment hospital like I do, you're certainly going to reach for that older agent that's cheaper first. But we do know the issues with gabapentin in terms of lots of sedation, especially initially, and then having to frequently titrate to get the desired effect for these patients can be difficult and frustrating for the patient as well. So those are, unfortunately, some disadvantages of using gabapentin, our older agent, so to speak. As I said earlier, NSAIDs can be utilized for bone pain, but again, he's describing, or this patient is describing, a different type of symptoms, so we need to think about that. Certainly, various types of antidepressants and even anticonvulsants are useful for neuropathic pain. Opioids are less effective in neuropathic as in comparison to nociceptive pain, which we just stated earlier. And we know that neuropathic pain is very common, especially when you've got some sort of tumor that's infiltrating a nerve or as a result of nerve compression, which certainly can be very common in a lot of these patients that have metastases to the bone. So you can see here again, just as a review, neuropathic pain is characterized by sharp, shooting, dysthesias, burning, gnawing, etc. Those are all kind of words that can be used from a descriptive standpoint to assess what type of pain the patient is having. So in this case, certainly answer C, gabapentin, is the best answer. I can't really give you any ideas in terms of how many questions you're going to get about pain management, specifically cancer pain on the exam. I would say, general rules of thumb, understanding, as probably all of you do since you're practicing clinicians, making sure that you know the conversions from one opioid to the other. In a separate board exam, I can recall there being other questions about titrations and converting from, IV to PO. So making sure you understand how to do that. And then also the major kind of ancillary medications that may need to be added to a patient that's perhaps on an opioid therapy regimen. So like your GI agents, maybe an antihistamine for itching, maybe something for nausea and vomiting for a patient that's perhaps a little opioid naive, so to speak. So those are kind of the key things I would say to focus on studying for the exam going forward. And those are likely things that you may not even need to study because you probably utilize those every day as part of your clinical practice. One other thing I would say, you may get a question about fentanyl patches because I think most people, when they think about cancer pain, they think about fentanyl patches. I would say that it's likely, I would doubt that you would get a question about transitioning perhaps a patient from a fentanyl patch back to some sort of IV or PO just because that kind of transition may change or the recommendations for what you use may change depending on where you look. So I think the big thing is just understanding the dosing of fentanyl patches, about how, the first 24 hours you may need an additional agent for until the patient kind of starts to feel efficacy from the patch, recognizing that they need to be changed every 72 hours and that kind of thing. Outside of that, I would be really surprised that you got asked any additional questions on fentanyl patches. Okay, so patient case number 5. You have a 50-year-old woman who's receiving adjuvant chemotherapy for stage 2 breast cancer. She received her 3rd cycle of doxorubicin and cyclophosphamide 10 days ago. Again, this is the AC regimen. Her CBC today includes white blood cell count of 600, segmented neutrophils of 60%, bands 10, monocytes 12%, basophils 8%, and eosinophils 10%. She is afebrile, which best represents this patient's ANC. A 600, B 360, C 240, or D 420. All right, some are quicker with the calculations than others. That's okay. Okay, so I'm seeing a lot of Ds. All right, so certainly ANC is very important if you work inpatient and have to follow patients that are getting chemotherapy. You know that myelosuppression is probably the most common dose-limiting side effect of chemotherapy regimens. I always tell my students, when in doubt, if you're worried about what the dose-limiting side effect of a chemotherapy agent is or the most common side effect of that regimen or agent, 99% of the time it's going to be myelosuppression. So if you're right with that, then you usually got the right answer. It is important, I think, that if you don't use this a lot in your common practice, that you do kind of refresh yourself with how to calculate ANC. It is the number of neutrophils plus the bands. And it's important in knowing the ANC in terms of predicting the risk of infection. So we know that when the ANC is equal to or less than 500, a patient is considered neutropenic. We certainly know that the risk of infection increases as the ANC drops below 1,500. Again, less than 500 is kind of the key mark in terms of neutropenia, and we know that the lower it gets and the longer it stays there, the higher risk for infection. Okay, so you can see here the ANC in this patient is 420. And the way that we get that is the white blood cell count times the neutrophils plus the bands. So we just converted those from, it was 60% and 10%. So we converted the percentages there. If you add those two together, then you get 420. If you work at a hospital, you may not have like at the facility I work at, they don't report segs and bands separately. They report it as percent granulocytes. So you would just need to know that, it's the white blood cell count times the percent granulocytes. Again, convert that from the percentage, and then that's how you get the ANC. Okay, so the answer is D, 420. Okay, so again, kind of looking at the case, 50-year-old stage 2 breast cancer, so we consider this to be adjuvant treatment, so she doesn't have stage 4 disease, so this isn't metastatic breast cancer. Third cycle of AC, which is certainly common, and her ANC and she has an ANC of 420. It is important to recognize that she's afebrile. Okay, so given this information, given her ANC, which statement is most appropriate? A, the patient should be initiated on colony-stimulating factor. B, the patient should begin prophylactic treatment with either a quinolone antibiotic or trimethoprim sulfamethoxazole. C, the patient who is neutropenic should be monitored closely for signs and symptoms of infection. Or D, decrease the doses of that should be AC with the next cycle of treatment. Okay, so I'm getting A, C. Okay. All right. So certainly if I had to guess where you would get asked questions from this chapter, it would, in my mind, it would either be on nausea and vomiting, or it would be on febrile neutropenia, or the use of colony-stimulating factors, and then maybe anemia, which we'll get to next. Okay, so if I had to recommend where you put your concentrated efforts to study, that would kind of be my recommendation. Again, this is just my personal opinion, but these are kind of areas where I feel like they're key concepts that are important in terms of the treatment, especially in the inpatient treatment of cancer patients. Okay, so the big question here is, do we use a colony-stimulating factor or not? And that was kind of the key point of the question, trying to get you to think about in what cases do we use colony-stimulating factor and what cases do we not. They generally are used to prevent neutropenia as opposed to treating established neutropenia. So that's a key component to remember. The big question you should always ask in the case is, does the patient have a fever? Okay, so if they don't have a fever, unless they have additional risk factors, you're typically not going to recommend for the treatment of neutropenia a colony-stimulating factor. Okay, and again, this is defined kind of in your chapter. Treatment of established febrile neutropenia should be considered when the patient is at risk for complications from infection. Some of those risk factors that are in your chapter, hypotension, multi-organ failure, sepsis, shock, etc., those would certainly be risk factors. The nadir ANC for most chemotherapy agents occurs at 7 to 10 days, followed by recovery. So it's important to refresh yourself with the definition of nadir. Nadir, remember, is the lowest point at which your counts drop before they start to increase. Okay, so usually, most commonly, most regimens, a nadir is going to be somewhere around 7 to 10 days. Now, is that every regimen? No. Some are going to be longer. Some might actually be a little shorter. But for the most part, this is going to occur in 7 to 10 days. If subsequent chemotherapy is delayed due to low ANC, a colony-stimulating factor should be given after the next cycle. Alternatively, the subsequent doses of chemotherapy can be decreased. And the big thing here when looking at this is curative chemotherapy versus non-curative chemotherapy. So this doesn't apply to all tumor types, but for the most part, we think about the easiest way to think about it would be curative really is going to be like a non-stage 4, so stage 1, 2, and 3. A non-curative, likely in the majority of tumor types, is going to be a stage 4. So that's one of the ways that you remember this. Where does this come from? Really, this comes from a lot of the data that's utilized in the prevention of prevention of febrile neutropenia for colony-stimulating factors was studied in patients who were being treated in the curative setting. And so there are a lot of practitioners that feel very strongly about not utilizing colony-stimulating factors in the non-curative setting because they really haven't been studied that way and validated that way. So that's kind of where that information comes from. So this is really talking about prophylaxis here. So in terms of treatment, as we just said, the big thing is that you look to see if they're febrile. If they're not, then chances are you're not going to add on a colony-stimulating factor. If they are febrile, then it would be appropriate if you wanted to add one on, or if the team is suggesting or asking if it would be appropriate to utilize it. The only time if they're afebrile that you would use it is, again, as I stated, if they have additional risk factors. So then when talking about prophylaxis, certainly if they've had a previous cycle where they've developed febrile neutropenia, then it is recommended that you can use these agents as secondary prophylaxis to prevent additional febrile neutropenic episodes. There's also some recommendations in the guidelines for primary prophylaxis, which honestly I don't think you'll get a lot of questions about, but it's really kind of looking at the patient up front, their risk factors, the risk of febrile neutropenia that can be assigned to their chemotherapy regimens, and making a determination there. If their febrile neutropenia risk is greater than 20%, then you could make an argument in the curative setting, you could make an argument that the patient would be eligible for primary prophylaxis with a colony-stimulating factor. I don't really think you're going to get asked to kind of make that determination. I think if you get asked anything probably with colony-stimulating factors, it's going to be whether or not in the acute setting, if they need it, so are they afebrile or not. Then if you get asked anything else, I would think it would be about side effects. So recognizing the big side effect of all of these agents, regardless of which agent you use, so filgrastim, pegfilgrastim, the biosimilar agent, or the TBO filgrastim, is that bone pain is the most common side effect, and kind of recognizing that. So one of your other options for answering this question was whether or not you should use prophylactic antibiotics. Typically, this is not something you're going to recommend for these patients, especially in this setting. This is a solid tumor patient. They're afebrile. When do you use it? You would use it certainly if they're febrile, certainly higher risk patient populations, your bone marrow transplant, your leukemias, etc. So the best answer here is C. The patient who is neutropenic should be monitored closely for signs and symptoms of an infection. Because remember, they're neutropenic, but they're not febrile. And it is important to recognize that most of these patients, you'll perhaps never find a true bug if they are febrile. Fever is the number one sign that they're going to have an infection. They may not even have any other symptoms, just that they're neutropenic and they have a fever. But certainly we are concerned about gram negatives and gram positives, especially if they've got an implanted catheter device like a portacath or something like that. So if you were asked a question about the treatment of febrile neutropenia, it's important to look and kind of see if that patient has any other risk factors. So if they have a catheter and they tell you in the case that they have a catheter, or if they tell you that they're hypotensive, they're febrile, and they're neutropenic, and they make you select an antibiotic, because of their, one, having a catheter, two, being hypotensive, then you would automatically think that you need to treat for MRSA as well up front. So that would be a situation where you would add, say, Vanc to a broad-spectrum antibiotic, like Pip/Tazo or Cefepime, et cetera. Again, I doubt you're going to get asked one of those questions, but that's just kind of a good rule of thumb, and I believe all of that information is in your chapter. Okay, so patient case number 7. This is kind of the third area I told you a few minutes ago that I thought you might get questions about. If you have a 45-year-old woman who's beginning her third cycle of chemotherapy for the adjuvant treatment of breast cancer, at diagnosis, her hemoglobin was 10 grams per deciliter. However, today, her hemoglobin is less than 10 grams per deciliter. The patient has considerable fatigue that is interfering with her activities of daily living. Which is the most appropriate treatment option? A, treatment with epoetin should be considered. B, treatment with darbepoetin should be considered when the hemoglobin decreases to less than 9 grams per deciliter. C, patient is being treated in the curative setting and therefore is not eligible to receive an ESA. Or D, the patient should not receive red blood cell transfusions because she is symptomatic. Okay, good. I'm seeing a lot of C's. So we'll kind of go through this. Okay, so fatigue in cancer patients does occur all the time. We actually understate this. most likely can be associated with anemia. We know that anemia is very common in patients. It's one of the major side effects of the cancer chemotherapy that we give. It could be kind of a multimodality anemia. Certainly chemotherapy-induced anemia, it could be because patients aren't eating as well, they're not intaking a lot of those key foundational components that are necessary to make hemoglobin, like iron, folate, etc. We know that there are certain tumor types that have a higher risk of anemia, and therefore we know that also there are certain chemotherapy agents that have a higher percentage of anemia as well. So there's kind of a lot of hypotheses in terms of why cancer patients get anemia. And then the one other kind of hypothesis that I didn't mention is that it is thought that tumor cells kind of release this tumor-inducing substance that actually decreases the overall lifespan of a red blood cell as well, so shortened from 120 days. So there's kind of a patient who undergoes chemotherapy, develops anemia, and subsequently develops fatigue, really can be from a variety of different mechanisms. Fatigue represents more than feeling tired and certainly can compromise quality of life. And we actually, as I was said a few minutes ago, we actually understate this. There was a survey done about 10 years ago that surveyed patients and also surveyed the physicians of those patients. And they were asking what they thought was the most kind of life-altering effect from chemotherapy. The physicians thought the patients would say pain. The patients actually said fatigue instead. Pain was second. So fatigue is one thing that patients are always going to complain about, and there's really, unfortunately, not a whole lot that we can do about it. So if we recognize that they are anemic, then that is certainly an area for pharmacotherapy that we could initiate. Attempts to increase hemoglobin with erythropoiesis-stimulating agents, or ESAs, have been associated with decreased survival in some cancer patients, and we know this to be in the studies that found a decreased survival was in patients where they were treating for a cure. So that's one of the reasons why, and kind of a key component to remember about this, is that you really never want to give ESAs in patients where you're treating for a cure. So again, if it's a patient that is, stage 1, 2, or 3, most of the time it's either going to be a stage 2 or stage 3, likely if they're getting chemotherapy, you would not want to use an ESA in those patients. So you would want to reserve ESAs, if you use them at all, for stage 4 patients, so non-curative type patients. So per national guidelines, the use of ESA should be limited to patients whose hemoglobin is less than 10 grams per deciliter. And if you've been a pharmacist for a long time, you'll know that this kind of trigger cutoff point has changed quite dramatically over the last 10 years. It used to be much higher, and that was actually the recommendation, that you should initiate these when the hemoglobin starts to drop less than 12, because there's a lot more to recover once it gets lower. But we know that this has since changed, since all of the data has come out showing that perhaps these agents decrease the overall survival. So 10 is kind of the magic cutoff. If you look at the American Society of Clinical Oncology guidelines, they do say that if you're going to use it between a hemoglobin of 10 grams per deciliter and 11, that should be at the physician's discretion. So really the recommendation is less than 10. And then, again, only use in patients with a non-curable cancer. So they should not be used kind of in the adjuvant stage where we're actively treating to cure these patients. I think you would probably agree with me that the use of these agents has dramatically declined over the last several years. At least at our facility, we're seeing more red blood cell transfusions, which is no surprise here. I think the other big thing to remember that this is an option. Transfusions are an option, but again, you have to wait until their hemoglobin drops fairly low before a patient ultimately would be eligible for a blood transfusion. The other big thing is just remembering, not to have a goal of having a super elevated hemoglobin. And that's kind of where a lot of these studies got in trouble. They were aiming for much higher hemoglobin goals than what we would do in traditional practice. And so, having a cancer patient with a goal of 10, a hemoglobin goal of 10, is not inappropriate, certainly. And so that's kind of a good thing to remember. But it can be a problem if it's associated with fatigue. So we will do everything we can to try to help treat that as much as possible. So just thinking about this case, this patient is being treated for breast cancer in the adjuvant setting. My guess is if they're going to ask you a question, they likely won't say adjuvant setting. They'll probably give you a stage. So in this case, ESAs would not be appropriate because we are treating this patient for cure. If this was a patient with advanced breast cancer or perhaps lung cancer, then these agents would be an option. And so it's just important to remember when you can use them for the exam and when you can't use them. And that's how I would approach answering every question. So the best answer for this case is answer C. Patient is being treated in the curative setting and therefore is not eligible to receive an ESA. Okay, patient case number 8. We have a 38-year-old woman who has a history of Hodgkin's lymphoma. 2 years ago, she completed 6 cycles of ABVD chemotherapy, which is doxorubicin, bleomycin, vinblastine, and dacarbazine. Each cycle included doxorubicin 50 milligrams per meter square. Recently, she was given a diagnosis of stage 4 breast cancer. So this is a secondary tumor that could perhaps be from her initial ABVD treatment. She will be initiated on doxorubicin 50 milligrams per meter squared and cyclophosphamide 500 milligrams per meter squared or AC for 4 cycles. Which of the following statements is most applicable? A, the patient has not reached the appropriate cumulative dose of doxorubicin to consider dexrazoxane. B, the patient has reached the appropriate cumulative dose of doxorubicin to consider dexrazoxane. C, the patient should not receive any more doxorubicin because she is at an increased risk of cardiotoxicity. Or D, the patient should not receive dexrazoxane because of the possibility of increased myelosuppression. Getting a lot of interesting looks. Okay, so this section is certainly moving into more of the chemoprotectant kind of section of the chapter. I'm seeing a lot of B's, okay, so we'll talk about that. All right, so the first thing we need to do is consider the total cumulative dose of doxorubicin. So we know initially when she received ABVD, she got 6 cycles. So 6 times 50 milligrams per meter squared is 300 milligrams per meter squared of doxorubicin, all right? And we know the kind of maximum lifetime dose is like 550, where patients really can start to see significant toxicity, so 550 milligrams per meter squared. Okay, so the recommendations in terms of chemoprotectant, specifically dexrazoxane, is that if you have a patient and again, this patient is stage 4 breast cancer, so that's something else to kind of point out, is that you calculate their doxorubicin total dose up to this point. Look at the goals of therapy. So this patient is a stage 4. So her treatment is going to be palliative. We're not, unfortunately going to cure this patient. And so that's something else to think about. And the reason for this is that there was an earlier study that showed decreased survival when you use dexrazoxane as a cardioprotectant to prevent cardiac toxicity. And one of the reasons why we think dexrazoxane kind of assists with cardiotoxicity is it kind of helps bind up those free radicals that we think is attributing the cardiotoxicity from the doxorubicin. So that's kind of where its mechanism of action takes place. The other thing we have to consider is dexrazoxane may actually add to the hematologic toxicity of chemotherapy. However, you want to weigh the risk versus the benefit. So what's the benefit? Perhaps preventing additional decrease in ejection fraction, perhaps putting that patient into heart failure versus causing a little more myelosuppression. So certainly those are things, again, risk versus benefit that a patient or a practitioner would have to weigh. So the recommendation is that dexrazoxane may be considered for patients with metastatic breast cancer who have received a cumulative dose of doxorubicin of 300 milligrams per meter squared or greater, and who may benefit from further drug. So we know that this patient has received a cumulative dose that is sufficient to consider the use of this agent. So therefore, if you answered B, that would be correct. The patient has reached the appropriate cumulative dose of doxorubicin to consider dexrazoxane. The other area that dexrazoxane is utilized is for the treatment of extravasations after the administration of doxorubicin. So just as a reminder of what an extravasation is, it's where if you're giving doxorubicin peripherally, and there can be some reasons for that, I guess, if patients not wanting to get a portacath or an implanted device, or maybe you need to administer chemotherapy right away. And so the doxorubicin, we know, is a vesicant. So if it's administered peripherally and the needle kind of becomes dislodged and starts infusing into the surrounding tissues, it can actually cause necrosis of the tissue, and so that's an extravasation. So another area you might see dexrazoxane used is for the treatment of doxorubicin-associated extravasations. I've only had to do this like one time in the last 5-6 years probably, but it did appear to be fairly effective. Expensive option certainly, but effective in terms of preventing the patient from having to go to surgery to have that area debrided. Okay, so I think we're getting to kind of like our final case here, patient case number 9. Which one of the following is the current sequence for administering Mesna and ifosfamide? A, Mesna before ifos and then at 4 and 8 hours after. B, ifos before Mesna and then at 4 and 8 hours after. C, Mesna and ifos beginning and ending at the same time. And D, Mesna on day 1 and ifos on days 2 through 5. All right, I must improve my questions. Okay. A. Okay, so this is the final chemoprotectant question. Mesna is considered a chemoprotectant, and I think it is just important to recognize, understand the mechanism behind which it kind of has its mechanism of action. It binds to acrolein. Acrolein is it binds to acrolein to prevent the binding of acrolein to the bladder, which is what causes hemorrhagic cystitis. So that's kind of where Mesna's mechanism does occur. High doses of cyclophosphamide and ifosfamide just in general can cause hemorrhagic cystitis. And so basically what you're doing is you're binding up the acrolein, which binds to the bladder, which is what causes the bladder bleeding or hemorrhagic cystitis. So whenever you use ifos, you're always going to use Mesna. Now, that's not necessarily the case for cyclophosphamide, but certainly if you're using high doses of cyclophosphamide, then you could make an argument that you may need to supplement that therapy with Mesna. So as I was stating before, acrolein is the metabolite of both of these agents that causes accumulation in the bladder, and so therefore that's why Mesna is kind of considered a chemoprotectant. When bolus doses of Mesna and ifos are used, Mesna should be given before ifos, then 4 and 8 hours. And so they really the thought process behind that is really to always kind of have Mesna available so that if there is any acrolein that's hanging around, it can bind it and the patient can kind of excrete it. So the answer certainly is A. Okay, so just a few things since I don't have a case on some of the oncologic emergencies such as hypercalcemia. We do have a few minutes left over. So just wanted to quickly comment on some of those things, and then at that point I'll take any questions you may have. Hypercalcemia, I would say out of all of the oncologic emergencies, or tumor lysis are probably going to be the two that you would most likely get asked a question about. The big thing with hypercalcemia, I think, is just to recognize if a patient has a low albumin, so an albumin less than 4, you are going to need to remember to correct for the calcium. So if that's not something you do on a regular basis, certainly making sure you go back and look at the corrected calcium calculation, that could be a potential area for question on the exam. Generally, if it's considered a mild type of hypercalcemia, then the recommendation is to initiate fluids, normal saline, and kind of pretty rapidly to encourage increased urine output. For your moderate to severe types, that's where you're going to be more aggressive with your bisphosphonates, et cetera. I say this because I think most of us probably know if you treat patients and they suspect hypercalcemia of malignancy, most physician is going to just initiate fluids and a bisphosphonate regardless of what the calcium is. And so I think it's just important. I don't know if you'll get kind of a tricky question like that on the exam, but I think just to recognize that for an exam question, if it's a mild hypercalcemia, initiating a bisphosphonate up front may not be the best answer. Okay, so just kind of keeping that in mind. Then certainly you have the use of rasburicase. How many have used that in your facility? Quite a bit. So do you guys kind of experience the what am I looking for? Dyspepsia, so to speak, of when you have to use it and tell your administrator that you're going to use rasburicase. They usually don't like that a whole lot because it is quite expensive. So certainly and I'm thinking ahead, I'm thinking about tumor lysis syndrome. So hold on just a second. So we've talked about hypercalcemia. Now moving on to tumor lysis syndrome. Tumor lysis syndrome would probably be the second oncologic emergency that you may get asked about. Certainly just recognizing what is tumor lysis syndrome and kind of what electrolytes you need to look at in terms of the laboratory values. Certainly you're going to have an increased uric acid. You're going to have a decreased calcium. That's how I remember that, because I remember hypercalcemia and tumor lysis are the most common emergencies, so to speak. So hypercalcemia, increased calcium; with tumor lysis, decreased calcium. So that's kind of, in my mind, how I separate those. And then everything else is going to be increased potassium, increased phosphorus, et cetera. So knowing that you're just going to treat those electrolytes the way that you would normally, hyper-K, et cetera. And then the big one you have to worry about is uric acid. So certainly initial treatment of choice is going to be fluids. Again, making sure that you're kind of pushing the rate so that you get maximum urine output. Certainly prophylaxis with allopurinol. And that can be quite effective, but in some patients it may not be. If you've got a lot of tumor burden, you may not be able to get on top of that. So then that's where the rasburicase would come into play. I think most facilities are kind of using the single-dose rasburicase. Would you guys agree with me, instead of the multi-dose? Yes? Okay. And again, recognizing that it is very expensive and making sure that you have done everything that you can in terms of pushing the dose of allopurinol and fluids before you make the recommendation to use rasburicase. So those are kind of the two oncologic emergencies I would think that if you get asked about, as long as you kind of know how to identify what those are and kind of what the recommended treatments are, you should be fine. The other things, superior vena cava syndrome and tumor cord suppression, really you're going to treat those very similarly in terms of cord compression, steroids, radiation, okay? And then superior vena cava, most likely patients are going to have a stent placed, and basically what this occurs from is just a tumor. Usually it's some sort of lung tumor or some sort of tumor that's growing in the chest, and it's pushing on the vena cava, which causes a backflow of blood. You can subsequently develop additional veins because the body is trying to compensate to get blood back to the heart. So usually patients are going to have facial swelling. You're going to be able to see the ancillary veins that have developed. And so usually the treatment of choice for that is if they can stent, they'll take them to the operating room, place a stent, and then perhaps steroids as well. So again, not as much pharmacologic treatment for that. So that's why I'm saying if they were to ask you a question about oncologic emergencies, it would likely be either tumor lysis or hypercalcemia of malignancy.